Welcome to the Recovery Playbook, brought to you by the Menninger Clinic, a national leader in addictions and mental health treatment. I'm one of your hosts, Dr. Daryl Shorter.
And I'm your other host, Ryan Leaf, and we are going to take you through some of the more exciting addictions treatment talk that we have, hopefully not only to entertain, but also to educate you and those that need to be educated.
Yeah, and today we are going to be talking about GLP-1 receptor agonists.
What are GLP-1s?
I'm glad you asked. So, glucagon-like peptide-1 receptor agonists, also known as GLP-1 RAs, are a class of medications that, if you haven't heard about them, I don't know how. I mean, everybody is talking about these medications.
Give them some names that are.
So you've heard of semaglutide, also known as Ozempic or Zepbound. There's tirzepatide, also known as Mounjaro. And these medications are FDA approved for treatment of type 2 diabetes as well as obesity, and people are using them either whether or not they have those conditions to control and manage their weight.
Recently, we've heard of a civil lawsuit out there against Ozempic, a very large number.
That's right.
You talked about individuals using this drug the right way or not, abusing it because of the weight loss attributes that come from them. Talk about why this was thought of by pharmaceutical companies. And why doctors prescribe them.
Yeah, so coincidentally, I mean, from the addiction standpoint, I don't think that they ever intended to use these medications for treating alcohol use disorder or tobacco use disorder. And to be clear, there's no indication from the FDA or anybody else, there are no clear guidelines that these medications should be used just to treat addictive disorders. However, what has been found anecdotally among people that might have had diabetes is when they were started on a medication like an Ozempic or a semaglutide, they found that their desire to drink alcohol, as well as even if they had a day where they were drinking, the amount that they were consuming went down significantly.
The idea around the drug is that it informs the brain when it's full. Right. Much earlier than the body used to before the drug was there. So those of us who love to eat, we would absolutely destroy the plate before we felt full. Yeah. And then we have overate in terms of caloric intake, where now this drug hits the receptors and lets it really sends a signal from your stomach to your brain saying, we're full.
That's exactly right. So not only are people experiencing early satiety, they feel full more quickly, they also have delayed gastric emptying, which means it's a fancy way of saying that your stomach feels full faster and empties much slower, so that feeling of fullness, you get a sense that you're like, well, I don't want to eat anymore because I already feel full, both physically and your brain is telling you that you're full.
So full disclosure, about 4 years ago, I went on a GLP-1, mainly for, I was pre-diabetic. My number was
hemoglobin A1C?
Yeah, A1C was right on that pre-diabetic number. And so I went on the drug. I would take a shot once a week. And I noticed pretty quickly the difference in my appetite.
Okay.
I never felt hungry. I never felt weak because I would still go to the gym and I would still do all the things I needed to do. I wasn't just absolving myself from any sort of exercise and just rather, doing that. I think the lowest I got down to was 209, which was too low for me, I think.
Okay.
I have documentation. You and I did a podcast in September of 23 here, and I see myself on the picture, and I'm wearing like almost the same shirt, and I'm really thin. Oh. For me, that like my wife pointed out, like I was really thin. I was like 209 pounds, which was absurd. I'm 228 right now.
Okay.
And feel really good and really healthy. But I will say this too, I had been sober for a long time, but whatever cognitive effects that it has on the limitation of, or the obsession to want to drink or to use, I just, on a daily basis, I understand what and who I am. I just didn't think about it. And I do think that my substance use disorder was incredibly symptomatic of being the symptom to my mental health diagnosis and old behavior. And so, but those old behaviors weren't cropping themselves up either. Like there wasn't addict behavior around what I was doing, which would then in turn me to, drug seek in any single way. So if that was a benefit to the health, now my A1C or my A1C level is absolutely like 5.1 now.
Wow.
Like it's non-existent. But that goes into all the food that we're eating, and we talked about earlier in an earlier episode where we started doing all non-processed foods.
Yeah.
That sure. And who knows if which one came first, if that applied to that or not. I think that the drug has been a godsend. I've recommended it to my father-in-law, who I think has needed it for some time later in life. And it's really affected him in a positive way, which has been great to see. We're having him move out to be near our family now.
That's nice.
To be around, he's in his late 70s. So I mean, there's always this conversation around pharmaceuticals and the pharmaceutical companies and the amount of money that they're making off these and that and other drugs. But there's the inventions of these pharmaceuticals that have been lifesavers in our lifetime. And who knows, because I think one of the biggest and most devastating causes of death in our country is obesity.
Absolutely.
I mean, heart disease. Those are the silent killers that are the ones that are doing it. And this may be, this generation's penicillin. Who knows?
So what's interesting about what you're saying right now is that it completely changes and challenges the way that we have historically thought about our relationship to food.
Right.
We typically think about our relationship to food as being emotional, as being psychological, and as being social, right? I go out to dinner with people on a Friday night to celebrate the end of the week and to have the development of a sense of camaraderie with people that I love and care about. And now I can do that on a GLP-1 RA and say, all right, well, instead of having an appetizer, 2 entrees and 3 desserts, I can have a little bit of an appetizer and kind of my meal, and then maybe take the dessert home with me if I decide to order one at all.
Or go no dessert, be a piece of an entree, and stick with the 3 desserts.
There.
Right? I'm with you on it. Like food, and it's the reason why my wife and I get along so well. We're both kind of foodies. We love to our date night does not have to be this over exaggeration of romance. It can revolve really around a new restaurant with a new menu, and her and I spending time with one another.
Absolutely.
And so I'm with you on that. Like the idea of and the understanding of your body just telling you you're full when you are.
Yeah.
I don't think it's trying to fool you.
No, not at all. And the interesting thing is it can really reduce our sense of shame and guilt that people experience as a result of feeling like, well, my weight is because of my weak will. My weight problems are because I'm just not a good enough person. I'm not disciplined enough. I don't exercise enough or hard enough or whatever those things are. And then you have this class of medications that comes in and really shakes up our conversation about obesity in a major, major way. And then you find out on top of that people drink less on this medication.
I think if you've done the research, if you've done the things that we talked about in previous episodes of going through the medical process, getting a blood test, understanding kind of where you're at. The only reason you're close to diabetes or pre-diabetic is the blood test, because you find out what your A1C level looks like. You have an understanding of what that is. And so the less sugar you're putting in your body, the better you're going to be. And, the drinking aspect of things is you're full sooner, and alcohol just becomes this thing that doesn't seem relevant anymore, maybe?
Mm-hmm. Well, I think what I want to make sure that we talk to the audience today about a study that was recently published in JAMA Psychiatry. This was in February of 2025. It's really the only study where they've looked at semaglutide, also known as Ozempic, in humans. It's a phase 2 randomized controlled placebo-controlled trial. And they found that low-dose semaglutide, it was a 9-week study, and they gave it at 3 different doses, reduced alcohol consumption during a laboratory self-administration. So they allow people to kind of go around and give themselves alcohol as much as they would have liked. It also decreased alcohol craving. People reported that they were drinking less per drinking day. And in a smaller group of people that also smoked cigarettes, it reduced their smoking too.
I mean, that type of data, which is one that the tobacco and alcohol lobby isn't going to like very much.
I'm sure they're going to love it.
But the people around the pharmaceutical conversation should be applauded for it, because what you're doing is, like anything, you're extending life.
But think of it this way also, right? Like, so you're also saying that biologically, there is something about our brains and our bodies where you can give someone a medication and they are now drinking less and smoking less.
Well, you and I have had these conversations around the opioid blockers.
Yeah.
You know, when we talked about Vivitrol and it being a non-narcotic alternative to help block those receptors, where it literally, if you were to choose to take some sort of opioid or anything, you would not receive any of the endorphin rush, that
euphoria from it,
that you would normally do.
Yep.
And how is that not a beneficial thing to make it more available to those people that are going through something like this? This is also a really good way to allow people to do things on their own terms, I think, too, where it's not like some of the hardest parts of getting clean or getting in recovery is admitting you have a problem.
Mm-hmm.
Like, that's the hardest part in a lot of it. Like, no, I don't have a problem. This is being heaped onto me by other people and everything like that. But I'd like to be thinner. You know, I'd like to look better in my jeans.
Yeah.
So if it's an excuse-riddled way you want to go about something, by all means.
Yeah.
I mean, to have this side effect, if you want to call it that, to a health and recovery aspect of things that could benefit something that you may have co-occurring.
Yeah.
Touchdown.
It's interesting. I was having a dinner meeting with some folks. This was a couple months ago, and one of the questions that they asked me was, would I feel comfortable prescribing something like a semaglutide for someone who has problems with alcohol? And what I offered was that while it wouldn't necessarily be the first, second, or maybe even third medication that I might prescribe for someone in the context of like severe alcohol use disorder, I would try the things that are sort of FDA approved and indicated. If that individual really still was struggling with establishing abstinence and they still wanted to have abstinence as their goal, would I consider it? I absolutely would. Now, this is off-label. I recognize that it's not FDA approved. And I also think that the desperation that many people experience as a result of their substance use disorder can be so great that to withhold that medication from somebody that's really, really suffering and really, really struggling, but hasn't responded to traditional treatment, that this could be an option for them as well.
And I applaud you for that. The desperation part is I know really well. So, like, I think a lot of the time we just want some sort of hope. We wanted, once I got diagnosed with the mental health stuff and understood that, like, the substance use disorder was just, you know, revolving around the co-occurring mental health diagnosis, like, that's huge.
Yeah.
The why, and this generation is just buried in the why. They want to know about why of everything.
Absolutely.
And so if you can give them something that can help with that why in some way, shape, or form, I think you would, if you didn't, you would be doing that client, that patient a disservice in trying to help them have a healthy and full-fledged life.
Absolutely. And there are ways to do it in a healthy way. Also, like, you would want to check the hemoglobin A1C. You would want to make sure that you're following this person medically and making sure that it's not an unsafe option for them. But again, if what we're trying to do is really help people to establish some sobriety and some recovery, and this is the way that you can jumpstart that for someone, I think it is important to at least consider it as an approach.
I hear Eli Lilly is close to making this in pill form.
Oh yeah, absolutely. So there are a couple of oral versions of semaglutide that are already actually being studied in clinical trials.
Yeah.
We're still waiting to hear about that. I mean, and listen,
But that's crazy though. That's amazing.
And a lot of the data we have right now is anecdotal. Like I said, this one trial is like one of the most robust trials that we've seen. And even then, they didn't have a ton of people in that trial. But we sort of know and hear people talking about it. And I think,
well, if there's anything new, it needs to be data driven.
Absolutely.
And so,
absolutely.
You know, I hate to use like, you know, when you say something like this to something new, our generation's penicillin, like the reason we know that about penicillin is because of the work it did
Yeah, that's right.
for so long and the data that's behind it. If you look at this 100 years from now and go, how many lives were saved because of obesity deaths, you know, high blood pressure, heart disease deaths, like we don't have the data to back that up yet.
Not yet.
You know, in this day and age too, you have to circumvent all the things that are come with it because Ozempic is getting sued for, I think, hundreds of millions of dollars because of side effects that come from that. It's just...
So it's about risk and benefit ultimately, right? Like if someone were to say to me that they had really no risks as a result of, you know, that they're not obese, they don't have diabetes, they don't have an alcohol use disorder or a tobacco use disorder, then maybe that medication has more risks for them than it would perceived benefits. But for somebody who's really super desperate and trying to get sober and they find that they can't do it, then maybe in some cases, the risk from that medication is outweighed by the potential benefits from it.
You know, I can just speak to its benefits. So, you know, that's, it's weird, of course, like anything else. Like some individuals who took opiates, the opiates that I took, they were sick from them. They didn't like them. It affected them negatively. Not that it didn't ultimately affect me negatively, but I loved it. Yeah. Right. I loved that it worked for me exactly how it worked for me. Whatever the combination of opiate and acetaminophen that was chemically mixed in those pills worked for me. And like anything, it can be that simple that it works for you. And a GLP-1, it worked for me. Yeah. And you know, I'm going to be 14 years sober here coming up in April. I've kind of got the life of my dreams. So I can't speak negatively to it. Yeah. I've had no side effects from it. And so, you know, this isn't an ad, but, you know, I could be the spokesperson for it in that sense. And so, and what this show does, and we hope it does, is that it educates those people who are asking the questions around, okay, so what is this product? How has it had an effect on, I had not heard of that study. I love being on this show with you because you always come up with new and you make me smarter because then I go off into the world then, and when I talk with people, it kind of sounds like I know what the hell I'm talking about. And I'm like, no, I have a doctor on staff. So it's very nice. Well, we thank you for being here. And if you have questions about whether or not GLP-1s could be helpful for you, talk to your doctor. Thanks, everybody. We'll see you next time.